Sure. I'm a nuclear medicine physician. I was born and trained and spent all my career in Bologna. Bologna University probably is not so famous, but it's the oldest academic institution in Western Europe. And I'm director of the nuclear medicine department here in Bologna, which is one of the largest in Europe. We are doing especially PET examinations, and my personal interest in recent years is about PET imaging of prostate cancer. Yeah, sure. I would say in the last 20 years, there's been an incredible growth in the imaging capabilities of prostate cancer. And in particular, nuclear medicine contribution has been terrific, because we started like almost 20 years ago with choline PET, which was interesting, even if not perfect. And thereafter, there was PSMA-PET that came. Well, there's been also fluciclovine in the meantime. So we have a number of new tracers, and they have completely changed the imaging approach to the patient of prostate cancer. So this has been largely used and established in the setting of biochemical recurrence, and it leads to incorporation into the guidelines. Now there's more and more evidence for the importance of PSMA imaging for staging, high risk, and for many other indications. And in the recent article that you just mentioned, we try to address which is the role of PET as a whole, but in particular PSMA-PET, in those gentlemen in which it's planned to have a salvage radiation therapy. So patients that have already been operated on with an early increase of PSA, so early biochemical recurrence, and for which there is a potential of radical retreatment with external beam radiation therapy. Well, detection, if you mean identification of the primary cancer, is mostly done with multiparametric MRI. There are other methods that could have been proposed, but the main technique is multiparametric MRI. PET imaging comes a little bit later, that's to say when you have to stage patients in which the cancer has already been detected. So for staging, especially high-risk patients, then PSMA-PET has a very relevant role. Because of course, in those high-risk patients, you want to exclude that there is an extension which may prevent your intervention from being radically curative. So that's an indication. And for sure, when you have biochemical recurrence, so when the patient has already been treated and there is a rise in PSA and you want to see where the recurrence has occurred, now it's well established that PSMA-PET makes a clear difference, and now it's standard of care because it's incorporated into either the European and the North American guidelines. So the change has been really dramatic. If you think that something like 20 years ago, there was almost no imaging. It was only CT and bone scanning, and both techniques are very well known to be poorly diagnostic accurate. That's to say that the prostate can barely be seen, or not at all. For bone scintigraphy, it's only about bone. And CT is not a great method to study the prostate, not to study the lymph node, not to study the early recurrence. So it's been really a revolution, and the impact has still to be fully established. And that was about our article. Because, you know, when you have already operated on a gentleman and unfortunately there is a recurrence, now the very typical approach is to perform radiation therapy in the prostatic bed, because you suppose that the recurrence has occurred there. But with imaging, you can definitely demonstrate that if the recurrence is there, so you are sure that you are irradiating the recurrent disease, and you see the extent. So if there is some lymph nodes, for example, that will not be involved in your field of treatment. And now you can make that with the PSMA-PET. The point is that the rationale is very strong. That's to say, given that you are sensitive, for example, in seeing lymph nodes, you can better identify the volume that you need to treat, or if there is a need for some systemic therapy or whatsoever. Unfortunately, what we don't have are robust, randomized, multicenter trials that do demonstrate an impact on major clinical outcomes, and in particular, an impact on overall survival. So it's something that is in the domain, let's say, at present of discussion, because you don't have any ABM trial that can demonstrate to every extent that having imaging will prolong the survival. But the rationale is very strong, because if with PSMA you can identify any area of recurrence, it's clear that you can personalize, you can tailor the treatment, and the patients will have a benefit from that. We have to be patient and wait for a while that some good trials will finish. Those are trials, of course, long-lasting, because the expectancy of life of those gentlemen is very long. It's trials which are not usually supported by big pharma companies because there's no drug beyond it. So essentially, you will have to run an investigator-promoted trial, and that's not easy in nowadays scenario. Oh, again, that's a major issue which stands between medicine, philosophy, and ABM, and so on, because medicine has been largely driven again by the ABM movement towards some demonstrations which are easily run for drug intervention. You know, all the trials promoted with the introduction of new therapies, new pills, can easily be done if you have a control group and you have your investigational group with an intervention which is directly modifying something that will lead to an increase, hopefully, in overall survival. But when your intervention is not just a simple intervention like adding a new drug or replacing the standard of care with something else, but you have an intervention which is adding an imaging, and the consequence of imaging could be different because you can have several options as a consequence of what you see. Then designing such trial is incredibly complicated, in some cases almost impossible, especially when there is a long survival of the patients and the standard of care may change over time. So this is one very methodological reason why it's difficult to have trials that can ultimately demonstrate that adding a diagnostic technique will immediately impact on overall survival. So we have surrogate endpoint, just like impacting, for example, on time to radiological progression. It's a surrogate endpoint. Or you have this logic of the rationale, as I just told you. If you have demonstrated that irradiating every pathological lymph node is a benefit for the patients, you can pretend that identifying better those lymph nodes will have a beneficial to the patient's survival, but it's not a direct demonstration of that. I'm sorry, it's quite methodological, and I have to admit I'm not a full expert of methodology, but it's just to justify, there's a long-lasting debate, you know, between the imagers, let's say, nuclear medicine and radiologists versus the urologist, oncologist, and radiation oncologist. That's to say, they say, okay, you are showing me one more hotspot, one more lesion, but treating that is really beneficial for the patient. I mean, I'm treating the patient for the survival, or am I treating the hotspot for itself? And they are right, because we have no final robust data in many cases to demonstrate that. But at the same time, The information that we provide are unique, are clear, are very accurate, because false negative and false positive are the minority. And the rationale is in favor of that. So we should collaborate to build some scientific evidence supporting that. And in turn, this will lead to incorporation into guidelines and daily practice and whatsoever. No, I mean, I guess that this is a perfect example, the salvage radiation therapy of an intervention which is cheap, it's relatively safe from side effects, it's done for many years, and we need a better strategy to drive it. And PSMA-PET could be exactly the perfect strategy to make this salvage radiation therapy at its best to customize the treatment for the patient and, of course, increase the quality and the duration of the results.